So I'd like to welcome everyone to the minimally invasive course and the ENT Forum 2024. It's wonderful to see everyone back here in Sarasota and some new faces as well. It's a sad thing that we're starting the day late, which means that the rest of the day is going to be even later. So please help me, all speakers, to stay on time so that we can catch the cruise boat at the end of the day. The way this is going to work is that this room is going to be primarily the otology and audiology presentations room, and the room next door is going to be the sinus, head and neck, general ENT room. So feel free to go from room to room. If you look at the schedule and see a subject that you want to attend, feel free to change rooms quietly. And that's why it helps for all the speakers to stay on time so that people can tell that at a certain hour, at a certain time, what to expect to hear on the podium. So I want to thank everyone who has been involved in the preparation of this course, speakers and exhibitors, and Christina, who is somewhere running around trying to put out fires. Our first session here is a combined session, which means there's nothing happening next door. Everything is happening here. And it's on the Eustachian Tube subject. So I'd like to welcome Dennis Poe, who just landed at 5:30 in the morning from Boston. He fought. Neither rain nor snow will stop Dennis from getting anywhere. So he apologized in advance if it does not make sense. It is not because he does not know the subject. Dennis?
Thank you very much, Jack, and everyone. It's a real joy to be here, and the coffee's great, so I'm doing all right. Herb, congratulations. It's a real honor to be here, although I'm not one of the fellows. You've always said I'm one of the honorary fellows. We've had a wonderful relationship over many, many decades. I'm so grateful. Thank you, Herb. Well, so we'll talk a little bit about Eustachian tubes this morning, and we've got some wonderful other speakers, so I'll stick to a few salient points. I am a consultant for Acclarent and Stryker. I don't do anything with Eustachian tubes with Stryker. Acclarent just pays me for time and expenses. I've got no royalties with these products, no equity interest in the company. So we've moved on from the idea that the bony cartilaginous isthmus, the narrowest part of the Eustachian tube, is likely the problem. It's really inflammatory disease in the cartilaginous portion of the Eustachian tube, which is adjacent to the nasopharynx and picks up all the same kinds of inflammatory pathology. So when we think about Eustachian tube disorders, it's just an extension of the nasopharynx. What we've got to get used to is looking at the Eustachian tube orifices when they're closed and open and assess how well they are functioning and how much pathology is there. So you've got to angle your endoscopes to be able to get that kind of view. And can we play that video, please? So this is what I typically do with a flexible scope, fiber or digital. I'm in the nasopharynx here on the left side, and I'm going to look at the right Eustachian tube across the vomer. So I turn the camera 90 degrees, and I'm flexing it back and forth across the nasopharynx. So we're looking at the right Eustachian tube here, and I just turn the camera back upright so I don't have to turn sideways. And I have the patients vocalize ka, ka, ka to see how the levator muscle is flexing and just moving the torus. Then they do a swallow for a normal dilatory effort, and then they do yawns and vocalizing ah to get a maximal dilatory effort. And that's the assessment. It's kind of like looking at the larynx and having them do other vocalizations. So you want that view, an angled view, and then go back over to the other side. Just a couple of cases with some pathology. So this is a right side allergic rhinitis, chronic middle ear effusion. So there's the lumen. The torus is swollen. You don't see vessels. It's inflamed, thickened, wet, lots of mucus. Look at the adenoid. It's only barely touching the torus. Not a factor, right? But watch what happens when she swallows here in slow motion. That thickened torus is being thrust up against the adenoid. And so in static, you wouldn't expect the adenoid to be an issue, but it turns out it's a big part of the issue. This is extremely common, especially in pediatrics. Your OSA patients often look like that. So when we talk about balloon dilations or other Eustachian tube treatments, that's not enough for this person. You got to consider the rest of the nasopharynx. And this dynamic exam with the swallows and yawns is what makes sense. Now look at this allergic patient. She's also got an effusion, but lots of inflammation here at the orifice, even bulbous polyp there. But look at that atrophy, a patch of atrophy. That's Ostman's fat, that yellow that you're seeing there through atrophic mucosa, submucosa. This is the paradigm you see with a chronic inflammatory disease, especially allergic rhinitis. They can become patchless. So if this person were to be considered for a balloon, you would actually be at risk for making them patchless if you overdo it. So it's important to look down the length of the lumen as far as you can when you're making decisions about how we're going to treat these people. Dr. Hoffman's going to follow and talk about how to sort out differential diagnosis, so I'm going to brush over that right now. But do keep in mind that the Eustachian tube, like most inflammatory conditions, it's a spectrum. So you've got left Eustachian tubes here and their corresponding ears, from complete obstruction over to patchless. And they've all got a basis in inflammation. So here, Samter's triad, swollen shut. You've got a middle ear effusion, less inflammation. Some air gets through. You've got a type C tympanogram, some retraction. This patient only has trouble when they fly, barrow challenged, normal TM. And see that redundant band here running along the floor? That's the most common thing that we see in these barrow challenged patients. They're great cases to treat with a balloon. They do really well. It's the minimum amount of disease. Now, if you've got that chronic allergic disease, you can get patches of atrophy, and this is known in the nose and sinuses. Turns out you can get that in the lumen of the Eustachian tube also. And these allergic patients in particular are notorious for starting out obstructed. They can become patchless. They can even go back and forth. And when their disease is active, they're blocked. When they're over-treated or quiescent, they can be patchless, and they're just going to fool you because they keep saying, I've got a blocked ear. And then keep in mind, this patient has a normal Eustachian tube. That's a retraction pocket that's fixed. Once it becomes fixed, the upregulated inflammatory mediators carry on and progress that retraction even to a cholesteatoma, regardless of what the Eustachian tube's doing. So we got to be discriminate. You can't tell if a patient has Eustachian tube dysfunction just by looking at the TM. So the clinical consensus statement from our academy established some criteria for candidacy for a balloon dilation. And basically, it's similar to what you would do with tympanostomy tubes, chronic middle ear effusion or non-adherent atelectasis. In other words, there's negative pressure, type B and C tympanogram, so you justify that there is negative pressure. And you can see inflammatory pathology in the lumen. That's what you're going to treat. Or if they're severely barrow challenged, very consistent history, you can still see the pathology, it's just going to be less of it. Now, if they've had a tympanostomy tube, that will clear their symptoms if it's obstructive dysfunction. So if a tube or myringotomy did not help, this is not obstructive Eustachian tube dysfunction, but lots of patients are getting balloon dilated when a tube did not help. So if the tube relieves the symptoms, but the symptoms come back when the tube comes out, that's a great candidate. I think most of you are probably familiar with what the balloon looks like. This is the Clarent balloon. So we've got some moderate inflammation there. You don't see vessels, some cobblestoning. This particular device has a guide catheter. It runs along the floor of the right nasal cavity here. That's the inferior turbinate. And all you have to do is just point it toward the orifice. You don't need to lift it up like I'm about to do, unless you want to probe around there. Sometimes you need to do that to find the lumen. So the point is, you want to line it up with this membranous wall, this anterolateral wall. The eustachian tube curves quite medially, and then it turns laterally to the ear. This device will touch the isthmus, and there's a little yellow marker there that should never disappear into the lumen, or that you'd be in too deep. And you keep it aligned here so it doesn't fall out. You blow it up to the prescribed amount of time that you already determined in the office. So lesser disease gets a lesser dilation. So maximal disease, I give the 2 minutes. If they're just a barrow challenge with that small band, just maybe 1 minute. Don't want to overdo it, make them patchless. So we've learned that the balloon, surprisingly, actually causes permanent histological changes. So biopsies taken before and after showed adenoid-like tissue here, follicles and inflammation in the surface epithelium. The surface epithelium got stripped down when the balloon got blown up, down to the basal layer, and so it's going to heal very quickly because the basal layer is still there, and the adenoid-like follicles are crushed, and they don't grow back in the post-op. So this is normal, healthy return of the ciliated pseudocolumnar epithelium, just what it would look like if you've done an adenoidectomy on somebody. So the balloon is just a tool to do an adenoidectomy on adenoid-like tissue inside the lumen of the eustachian tube. That's how you want to think about it. And if it works on a human, it should work on a rat, right? So here's a rat study. It was done recently, and sure enough, got exactly the same kind of results. The clinical trials, all of the clinical trials, all of the systematic reviews, meta-analyses, and all of the studies with mean follow-up of 2 or more years, long-term follow-up, they've all shown benefits. Not a single one has failed. And so it's been with proper patient selection, people get great results. So the latest news is that the Clarent balloon was approved for pediatrics down to age 8. That happened in December. So that followed a number of studies with this German balloon and studies from Germany showing benefit, and a systematic review putting all that together, including some of our studies, has concluded that the benefits are excellent in kids as well, and with a good safety profile. Here's 2 studies that we did. This one is Boston Children's Hospital patients. We took patients who had 2 or more tympanostomy tubes. These are kids, previous adenoidectomy in almost all of them, and they're still looking like they need another tube. And so this cohort got the balloon dilation in addition to their latest tube, and the rest were matched controls to see what would happen over time. This is a 2-year follow-up, and it was a very strongly statistically significant difference. The balloon group changed the curve of that natural history. And then over here, Dr. Mark Dean was the surgeon here, did a nearly identical study, and you can see what he's got actually now up to 6 years follow-up. Very similar statistical significance. This works. Watch out for the patchless eustachian tube. It's extremely common, and the patients will tell you they've got that blocked ear. All of these chronic-looking ears have patchless eustachian tubes, so you can't tell just by looking. 30% of my patchless patients look like this. They started out obstructive, they moved to patchless. And watch out for the kids. They'll be sniffing. You think they've just got allergies. They're sniffing frequently because they've got patchless. And you get a tube. A tube can help a lot of patchless patients. And so they're thinking that, it's obstructive dysfunction, and now we don't want to balloon those kids. You've got to ask about sniffing. That's what they do to control their symptoms. So watch out for patchless, and allergic rhinitis has been the most common comorbidity that we see with that. Watch out for these allergic patients who are sniffing. Office treatments that you can do for patchless, good hydration, nasal saline drops. We have the mix-up hypertonic saline, 4 teaspoons of salt in a cup of water. Gives you pretty good hypertonic saline. You have to coach them how to do it. You can give Patchul End. That's over the counter from Joe DiBartolomeo's office in California. They can work, so they're pretty good. They can at least give some temporary relief. You can mass load the tympanic membrane. I do a stack of 3 steri-strips stuck together. This is based on Manohar Bansa's work. He started out doing blue tack and then ointment. But if those work, and the patient's coming back, hey, I like that mass loading, paper patches, you can put a tube in, it'll do the same thing. If they like the tube but it keeps falling out, you can do a cartilage graft tympanoplasty. More advanced stuff would involve different kinds of plugs. There's a commercially available shim in Japan and Korea. We don't have that. I have to use an angiocatheter to duplicate that. And that, just to show you that really quick. So there's an angiocatheter coming here. Let's see. I think we're right there. So I just slide it up there just the same way you would do with a balloon. But I want to stay on time here. So in conclusion, Eustachian tube dysfunction, you've got to do a comprehensive evaluation. You can't just look at the ear. So that whole history, their otoscopy, audiometry, do they actually have negative pressure, tympanometry, and what's that endoscopy look like? In the kids, if you go below age 5, many of them have reflux of nasopharyngeal pathogens. It's infectious or a reflux from the stomach. Over 5, kids should outgrow it. Think about allergies. We send a lot of kids for allergic treatment. And remember to look at both walls. It's a valve, just like the larynx. Look at both walls. Treat all the relevant pathology. I do a lot of lateral adenoidectomies in these OSA patients and in the kids. A lot of revision adenoidectomy to get that lateral part out. And I'll even trim some of that tubal tonsil tissue with a light cautery, 15 watts. So just think of it as an adenoidectomy on adenoid-like tissue. And remember, if a tube didn't help, it's not obstructive dysfunction. It's something else, patchless, TMD. Karen, that's going to be your talk. Thank you.
Thank you, Jack. Herb, congratulations. What a history. And 50 years, not only teaching fellows and locally practicing, you're internationally recognized ENT surgeon that around the world you were able to impact a lot of clinicians, including me. And I'm not an otologist and I'm not in Sarasota. So a great event, great history. Thank you very much for all your input over the years. I'm going to leave most of the controversial stuff for the panel, and this is just an introduction. Here's my disclosure. I'm a CMO at Valent Medical, which is a laser company and other ENT devices. When I look at the nose, I stop at the nasopharynx after my nasal examination. The reason I stop and I don't go into the larynx is I want to look at the nasopharynx dynamically, statically, and look at the structure. Two areas that I look for, one is the torus, the other one is around the fossa Rosenmüller and the nasopharynx itself. And then I go down to the palate and I let the patient snort, ka, etc., and check the function of the Eustachian tube statically. The Eustachian tube dilates 1.4 times per minute, and it's a very short episode that happens. And the reason it does that, to protect the ear and drain the ear and also equalize the pressure. This is an underdiagnosed entity, Eustachian tube dysfunction. It's either obstructive or patulous. We don't understand it well, and the general clinicians, they miss this entity. It's an opportunity for our specialty, both on the otologic side and the rhinologic side, to get in there and work on this particular topic. An interesting case that I'm going to show, on the right side, he had an obstructive symptoms, and on the left side, because of that adhesion, he had patulous symptoms. So a question for Dennis during the panel, can this happen? You know, one side has obstructive, the other side patulous issues. It's not a tubular structure. It's a soft, floppy area, maybe 60% cartilage. And when we dilate, we're dilating this lumen and causing pressure. And Dennis showed what's happening to the mucosa and the submucosa. The cartilage returns back in its position. So you're really doing a mucosal compression with a stiff balloon. Not the same as dilating the sinus passages where you're cracking the bone. So bear with me for a couple seconds. These are my favorite histoanatomical slides. Goes back to my residency. This is the left side of the nose, the back of the nose, the back part of the inferior turbinate septum, the muscles, lateral muscles, the pterygoids, etc. Foramen rotundum, we're approaching the area of the nasopharynx. We exit the nose, fossa rosemuller, the beginning of the cartilaginous area, the tube kind of opening, and here a little bit further posterior, a little adenoid tissue, the muscles, the tensor, the levator, and as we go further lateral, lumen appears. And this clearly demonstrates how the lumen is flat. Here's a little bit further higher, and this is the V2 foramen ovale area. So that clearly shows you and understand the histopathology of the Eustachian tube. And why I'm saying that, the anatomical relationship with the tube is critical. And I'm going to touch on, can nasal surgery improve the Eustachian tube function? Is a paper. This is our study treating the posterior aspect of the turbinate. Can that improve the Eustachian tube function? Our conclusion was yes, and you will find many posterior turbinate hypertrophy that's literally touching the Eustachian tube. Imagine on top of that you have secretions, discharge, allergic issues, etc. Quite easy to ablate this kind of herniated posterior aspect of the turbinates and treat both the nasal obstruction and also the Eustachian tube function. So, and you will see many cases, even total turbinectomy and full house endoscopic sinus surgery, that you still have issues with the posterior remaining portion of the turbinate. Now we have tools that can reach that area in the clinic very easily to decrease the volume of the posterior aspect of the turbinate. This used to be a no-touch zone 10 years ago or more, okay? Here, safely, local anesthesia, decompress the structure and drain whatever it is that it's happening in that retained posterior aspect of the turbinate and improve function. Nasopharyngeal pathology you can treat in the clinic. And that's critical for someone like our specialty to do minimally invasive procedure under local anesthesia in an office setting. And marsupialization is sufficient for this type of lesions. Obviously, a center lesion like that, two of those, it does not interfere with the Eustachian tube. I'm demonstrating that. The one on the right-hand side, much bigger, much more involved, and we can approach the nasopharynx from either side, obviously. You can put your ablative instrument from one side and the telescope from the other, and join hands and treat the nasopharyngeal pathology from both sides of the nose. So what happens if the cyst is in the fossa rosemuller? I get nervous. And simply because a case like that, filling the fossa rosa Mueller. I like to see an open, empty fossa rosa Mueller. That's my ideal normal anatomy. When something is filling the fossa rosa Mueller, there is some sort of Eustachian tube pathology and dysfunction. Some minor, some major, you don't know. We did a CAT scan, we looked at the anatomy, etc. This was a clearly bronchial type cystic retention area, condition, and I felt confident that I can treat this in the office. Why? I have, number one, ideal patient. Number two, I have the instruments and my staff is trained. We'll talk about how to select the patients later on today. And if need be, you can obtain and do a biopsy and send it to pathology, confirm the finding, et cetera, and this heals well without any issues. So let's talk a little bit about another topic that I like to bring up. What happens if the torus tubarius is thickened? Dennis showed a case or two, and I think we should have some sort of a classification of the amount of thickened lymphoid tissue that causing significant pathology on the Eustachian tube area. And one thing that we are missing in our specialty is maybe a tuboplasty scenario. And tuboplasty did not really move forward for many years. I'm going to pass on this due to the time constraints. Let me focus on the tuboplasty. Multiple papers in the literature. And you will see European literature. You will see Dennis's paper here doing laser with the CO2 and other laser devices, trying to improve the function of the Eustachian tube by doing tuboplasty. Another paper from Dennis and Ralph Madsen from Boston using a microdebrider for tuboplasty. Here is another one using quantic molecular resonance, QMR, to decompress the torus area. And most interestingly, here, a laser versus microdebrider Eustachian tube tuboplasty, comparing the two. Where are we with this? I can tell you what the problem is. The problem is we don't have a CPT code. Okay? Huge amount of literature, we're not addressing the problem. And we will talk more about this topic. Now, the reason I like this particular laser fiber tip, it's flexible, malleable, 400 micron, can reach the nasopharynx. You can do the work in the nasopharynx very easily. And here are a couple cases of Eustachian tuboplasty, and reach the back of the nose, interstitially and submucosally, decompress the thickness. These cases were done under anesthesia. And at the same time, you can also decompress the Osman fat pad, reduce the fatty substance within the region as well. So there are multiple variations. You can clean the tonsil tubal tissue. You can do combination of dilation and tuboplasty at the same time, like the one on the right side, et cetera, et cetera. It's an opportunity, and we should get involved. I will close the talk with, there is an issue with venous plexus in the pterygoid area, and this is one case example. What has happened is there such a thing as congestion of the Eustachian tube structure, the mucosa, submucosa, etc., that is building severe edema that is causing these difficulties. these difficulties within the Eustachian tube. Here is one case example. I have no proof of it. I didn't do an angiogram, I didn't do any study, but you look at it endoscopically, it's blood vessels all over in the submucosa. Can we shrink those blood vessels and improve the function? We have the tools in minimally invasive under topical anesthesia, spray the nose, blanch the vessels, etc., etc. So we can do all that. Thank you very much.
Thank you, Joe. So we're going to reserve questions and discussion for the panel. Next, Karen Hoffman is going to talk about not all ear fullness is Eustachian tube dysfunction. Karen?
Great, thanks. All right, I'm so excited to be here. Thank you, Jack. Thank you, Herb. Appreciate the opportunity. So Dennis did a really great job telling us about what patients have chronic obstructive Eustachian tube dysfunction. But I want to know, what do I do with those patients that don't have either patulous obstructive or barometric challenge Eustachian tube dysfunction? So I like to get as much objective testing that I can so I can figure out what to do with these patients, because we know we're all seeing them. So if they have a normal tympanogram, we've looked at reflex decay tympanogram, so they don't have patulous, they don't have autophony of voice or breathing. We do SNOT 22s and EDQ 7s to get a measure of how severe their symptoms are. So what do I do with that patient that has a normal physical exam? The TM looks normal, the middle ear is normal, the mucosa, when you look at the Eustachian tube orifice, looks like this. This is actually a patient that has patulous Eustachian tube dysfunction. So these are the patients, as Dennis said, you don't want to dilate those. But what do you do with them? So if they don't have Eustachian tube dysfunction, they don't have a history suggestive of cochlear hydrops, superior canal dehiscence or TMD, then we need to think about what else can there be, what else is going on. So we look at CT imaging of the sinuses and terminal bones. I don't mean the 2 millimeter cuts, I mean very fine cuts of CT to figure out what's going on. Because we know we're all seeing these patients. So if you look at a tertiary care rhinology clinic, 43% of the patients report symptoms consistent with Eustachian tube dysfunction. And they also found that you can have increased SNOT 22 scores are very highly correlated with increased EDQ 7 scores, even if you're only looking at the rhinologic symptoms. So patients presenting for treatment in a rhinology clinic and most of our ENT clinics are likely to have increased prevalence of otologic symptoms. I would say as an otologist, my patients are the same thing. I have otologic patients that have a very high likelihood to have rhinologic symptoms. So I figured out years ago, if I don't fix the nose, the ears don't get better. And this is really why. There's an isobarometric reflex arc there with mechanicoreceptors located in the mucous membrane linings of the Eustachian tubes, the nasopharynx, the middle ear, the TM, and the sinuses. So you get signals from the sensory receptors that travel along nerve pathways to the brainstem. Through the ear, it's via the tympanic plexus and the glossopharyngeal nerve, the sinuses due to the trigeminal nerve. So the signals are processed, and then the brain activates the tensor veli palatini via V3 and the levator through cranial nerve 9 and 10 through the pharyngeal plexus. So once those muscles contract, they open the Eustachian tube, it equalizes the middle ear pressure with the ambient pressure. But things can disrupt that. So we're going to look at that very briefly in the anatomy to figure out why. So through the otic ganglion, it'll become important that it lies just below the foramen ovale. So the facial nerve through the chorda tympani goes to the otic ganglion to the vidian nerve, and through the pterygopalatine ganglion to the levator. There are other muscle fibers that traverse the otic ganglion that then go to the tensor veli palatini. That's your reflex arc there. You've also got sensory fibers directing the other direction. So you've got the sensory root from the mandibular nerve. It receives those fibers from the glossopharyngeal via the tympanic plexus and the lesser superficial petrosal nerve. So in the middle ear, you have the tympanic plexus. There's a network on the promontory. The vast majority is coming from the glossopharyngeal nerve, providing sensory innervation to the mucosa of the middle ear, the mastoid, and the Eustachian tubes. And that's where you get these fibers conveying information predominantly about pressure, but maybe temperature and chemical stimuli. From the facial nerve, you have parasympathetic fibers that go to the greater petrosal nerve that make up the vidian nerve. There's a little sympathetic plexus also. So then we look at the vidian nerve. You've got parasympathetic fibers from the greater petrosal nerve, branches of 7, and that's the principal constituent of the vidia nerve. You've also got some sympathetic fibers. Those fibers pass through the pterygoid canal, so you've got the facial nerve to the otic ganglion, to the vidia nerve, to the pterygopalatine ganglion, which then goes to the nasal cavity, paranasal sinuses, and pharynx. So where that becomes really important is when you look at the sphenoid sinus neuroanatomy. So like the bottom left picture, find the pointer. So if you have bony remodeling or thinning of the bone in the sphenoid sinus, you have very close approximation to these critical nerve structures. Like we talked about the foramen ovale being close to the otic ganglion, then this is the foramen ovale, foramen rotundum where V2 is, and also the vidian canal here. So you can have neurovascular exposure in the sinuses that disrupt that isobarometric reflex arc and can lead to dysfunction of the autonomic nervous system. Now, this occurs because of the size of the opening of the sinus ostium. So in a normal sinus ostium, this is from radiology literature, should be between 3.5 and 5.5 millimeters. So this is, This is, normal patients are around, I see a lot of them around 4.5 millimeters. When it gets below 2.5 is when I start seeing more patients with more problems. So my patients that come in with these symptoms typically have sinus openings that are about 1 to 1.5 millimeters very commonly. And so that's the bony opening. But what happens when you get a lot of mucosal inflammation, whether you have reflux, allergies, chronic rhinosinusitis, narrows those sinus ostia even further. And so what you end up with is pressure changes inside the sinus, which then can lead you to pneumosinus dilatans, which is an abnormal expansion of the paranasal sinus cavity, either part of the sinus or the whole sinus, and so you get bony walls that are displaced outwardly beyond the normal borders of the sinuses. So you can see that if you look here, extending anteriorly to touch the maxillary sinus and laterally. And so these sinuses, because it's a pressure changes, you only get you don't get mucosal thickening because of the pressure in the sinus itself. So bony remodeling, you'll actually see on the CT scan as uneven, irregular, or thinned over prominent structures. It can be brain and eye, but what we're talking about predominantly is the neurovascular structures. In some radiology literature, flattening or erosion of the rims of the vidian canal, which we have seen right through here, vidian canal and V2, those are the most specific evidence of expansile or erosive process within the sphenoid sinus. So the most prevalent theory about why this occurs is because it's obstruction of the sinus ostium. Remember, it's very small in a lot of these patients, causing expansion of a ball valve effect due to pressure in the sinus. You get pressure in the sinuses, it causes bony remodeling, it exposes the nerves. So it's a one-way valve caused by mucosal inflammation or narrowing of the sinus ostium and mucosal inflammation on top of that. So the symptoms that you get for pneumosinus dilatans depend on which structures are involved. So you can get localized discomfort, ear fullness, facial pressure, headache, paresthesia, some sensory deficits. I don't see a lot of olfactory loss, but that's possible, and ocular abnormalities. So when you look at the nerve exposure, you get V2 right here, you get the vidian nerve right here that is exposed to the sinus. As you get pneumatization to the anterior clinoid process, there's a very high indication that you can get dehiscence over the optic nerve also. So how do we fix that? Now, if we can identify it, what do we do about it? So they have shown studies that show controlling the symptoms occurs when you open up that sinus ostium and improve ventilation. So that can be done through an osteotomy, from functional endoscopic sinus surgery, and some later studies show that balloon sinuplasty can be effective in opening that and stimulating new bone formation on the walls of the sinuses. All right, so I looked at my patient population over the last 2 years. This is just the last 2 years, so our long-term data is somewhat limited. I took all of my sinus patients, so the vast majority of my patients, because I see those patients that get the earfulness as an otologist, have variations of chronic rhinosinusitis on top of pneumosinus dilatans. But I do get nasal polyposis patients too. So I looked at pre-op and post-op SNOT scores. In a perfect world, I would have EDQ-7 scores for every one of these patients also, but because of disruption of clinical flow and easier completion of the patients, I just followed the SNOT 22 scores. So for those patients that we had incomplete data, most of it was because they followed up with either my PA or one of my other partners and we didn't have data. But we have average data for the past 7 months, and then my ultimate goal to follow these patients is seeing them every 3, 6, and 12 months and on a yearly basis, because I'd like to get some long-term data. So when I looked at my patient population, my average pre-op score was 45, and average post-op score was 21. So significant improvement, and then I had patients improved at 94%. So I know all of you want to say, well, what about those 6 patients that didn't get better? Why'd you make them worse? So I looked at that data. I'm not going to go over all of it very quickly. So first patient had a history of patchless Eustachian tube dysfunction. I put a shim in with a limited sinus surgery. At 14 months, he was feeling great. His ears were fabulous. He just had some sleep problems. At several patients have presented not with ear fullness, but chronic rhinosinusitis with nasal polyposis. And I'm in Atlanta, so we have terrible allergies. And so we had some severe allergic responses for patients that they were great until their allergies kicked in and then they got worse. So we're dealing with those medically. And then, let's see, I had one patient has persistent facial pressure. We're still working that up for maybe mid-facial migraines. And one patient that has also severe allergies, she got worse. We are looking at revision surgery for her, and what I found that sometimes I need to be more aggressive in opening up some of the sinuses, including the ethmoids. So that's my synopsis of the patients that weren't better. All right, so what I would say is when you're doing, just like Dennis said, it's a great option to be able to dilate those patients that have obstructive Eustachian tube dysfunction. You do not want to dilate those if they have not gotten better with tympanostomy tube placement, or they have a completely normal exam with no mucosal inflammation in the Eustachian tube orifice, because you're going to dramatically increase the risk that you will develop patchless Eustachian tube dysfunction. And we all see these patients, but be aware that otologic symptoms are often accompanied by nasal symptoms. So you want to think outside the box. Part of the reason that we don't look for or we don't identify pneumosynus dilatans more often is that we are unaware of what pneumosynus dilatans. So when you actually start looking for it with CT scans and fine cut CT scans, you will see it much more often than you think you will. And so that's objective evidence of narrow sinus ostia, bone remodeling, pneumosynus dilatans where it exposes beyond the normal borders, and exposure of those neurovascular structures. So FES and balloon sinuplasty can be very effective in opening those sinus ostia and relieving the pressure on the nerves, but it's also important medically to control all the sites of inflammation to get the best surgical outcome, or the best outcome for the patient. All right, thank you very much. That was speed talking, but appreciate your time.
Speed talking, but you kept us on time, and I'm sure you've raised a few questions. So let's address all of this during our Eustachian Tube panel. Joe, you're the moderator for the panel. So why? Because you are the novel approach man. So. Would you like us to come up to the podium?
It really doesn't.
Reminded me when I joined the faculty after my fellowship, and I came in as the otologist, and I was doing a few rhinology and sinus cases, and I was attacked by the rhinologists there, saying, "What are you doing in the nose? You're an otologist." And I remember saying, you cannot artificially separate what God intimately created. So, so Joe reminded me of this because I mean, our whole otological career is very much related to eustachian tube dysfunction and allergies and so on and so forth. So we're linked in the nose.
No question. And I think this is a good leeway. And I will start with some issues that can relate to a general otolaryngologist, and this is reflux laryngitis, pharyngitis, severe lymphoid hyperplasia on the throat, patchy pharynx, lymphoid tissue all over the place. And this patient has the symptoms galore, right? So what do you do? Let's start, Dr. Cocker.
Put me on the spot with the most difficult case. I mean, this is a difficult problem. I mean, obviously, you're going to control the reflux as much as you can. You're going to do an allergy profile, allergy testing, see what the allergy components are, aggressively treat the allergies as well, and then probably talk about the adenoidectomy, or at least reduce the bulk of the adenoidal tissue. And then the questions then arise, can we use biologics in these patients who are not responsive to treatment? So there'll be a whole plethora of options we have.
So this is not a surgical case, is that what you're telling me?
Initially, yes. Initially, you have to optimize medical management followed by an adenoidectomy, and if eustachian tube's involved, then treat the eustachian tube.
You agree, Dennis?
Yeah, I completely agree. You know, most of these inflammatory conditions, we want to start with medical treatment, and the majority actually will get better and not need surgery. So the important point of the medical treatment is to get things under control, optimized, and if they persist with their symptoms, although you think that they're optimally controlled, that's a great indication for surgery. Wipe the slate clean, keep them under medical management so the inflammation doesn't return.
I don't have much to add there. I agree.
Good.
We start with medical management all the time.
Good. The question is, reflux can impact the nasopharynx and the eustachian tube function? Yes or no? Maybe, to some degree?
I would say yes. It also affects how the sinuses function, particularly we're talking about the sphenoid sinus.
Well, I'm glad you're raising the sinus issues because here is a bad nasopharyngitis with salpingitis, an acute infection, severe pain, discomfort, fever. And you can see the bubbles from the eustachian tube into the nasopharynx, pharyngitis, etc. What if this situation is recurrent, keep coming back?
Have you checked out the sinuses? Because you want to address, we can't, like Jack said, we can't treat it as an isolated incident. So you want to deal with everything that you can identify. We're ENT, so you want to treat aggressively the sinuses and then medically manage all that and then address the eustachian tube stuff if you're talking about dilation. So you can culture, you can do DNA sequencing, we can do sinus CT and treat the sinuses, and then oftentimes once those are healthier, the eustachian tube will also improve, but then consider treatment if it's not better.
I agree. I mean, and I would say that you would also look them up for chemical, like again, we're talking about reflux and other things, like when you have reoccurrent stuff, it's not just bacterial. I mean, you're gonna have immune compromised things. You wanna make sure they've got a competent immune system. The reflex arc that Karen talked about just a second ago, actually some of those mechanical sensors, pH of 6 is actually one of the most inflammatory things within the nose and the nasopharynx. And so pH probes and getting into that area, making sure a lot of this acute inflammation and pain isn't glossopharyngeal neuropathy triggered by reflux.
So Jack, can salpingitis stop in the nasopharynx and not be involving the ear? And this is a good case example. This case did not have any ear issues. You can see the nasopharynx is severely swollen, inflamed. The torus is red, swollen, edematous, etc. But the ear was okay.
Well, I think it's a lucky break.
Okay.
I think when you have such disease in the nasopharynx and around the eustachian tube, you know, if I have this multiple choice question on the board, I'm going to say yes, the ear will be involved in this.
I would say that this gets to what Dennis said earlier on, especially if you mentioned this was reoccurrent acute, like that, you know, over time that bulk of disease is going to create atrophy, which then was going to prevent some of this stuff. So this could have even been a patchless patient that got better with the inflammation, or over time the bulk of the disease will have thinned out the fat pad enough that it doesn't block off as much.
All right, back to rhinologist, Dr. Kacker. Sinusitis and Eustachian tube issues.
I mean, as Dr. Hoffman mentioned, most of the patients who come with sinusitis will have some degree of eustachian dysfunction. It's matter that is the sinuses bother them more or the ear bothers them more. So all of them will have it. This, you can see the classic thick peanut butter stuff going down the eustachian tube. This person will be miserable with the ear and the sinuses, and so both needs to be addressed.
So if you see pus in the nasopharynx, it means that pus in the eustachian tube. You're treating the sinuses. Will you treat the eustachian tube with a balloon as well?
I mean, so as long as there's acute infection and pus, I would probably control it medically and then consider a tube for a balloon dilation for whatever symptoms are left. I mean, obviously this person, CT shows that he's got a completely opacified maxillary sinus which needs to be addressed as well. At that point, after medically controlling him, probably will balloon both the maxillary sinus as well as the eustachian tube if they're indicated.
So at one point here is I'm trying to look into the lumen of the eustachian tube, and although you've got pus draining across it, I'm not sure that there's a large degree of inflammation within the lumen of the eustachian tube. That would be critical in determining should we balloon it or not, assuming you've gotten the sinuses under optimal control. So again, you want to take a look and see what's the burden of inflammation before you're going to instrument it.
Functional test to see how. I mean, I think the one thing that we're missing with all of these conversations is, while endoscopy is important, I think otologic functional tests of the eustachian tube are critical. If you've got a normal patchless eustachian tube that's able to ventilate, doing a dilation is not appropriate, no matter what it looks like. And so it can't be on just physical exam alone. It needs to be on functional testing. And I think most of the randomized controlled trials all have used that as one of the markers for both indications and for success.
So when you're talking about dilation in those cases, we're not talking about dilation right now. We're talking about right now there's an acute infection or an acute in a chronic case infection, and that's the medical treatment. This is not the time to dilate. And in my mind, dilation happens if this is a recurrent problem affecting the eustachian tube, then we could dilate the eustachian tube. But as Mark said, we need to have evidence that the eustachian tube is causing ear disease for us to go in and dilate it. Right now, right here, I see just medical therapy and maybe sinus ballooning and treatment, because that's the source.
Dennis, why we're not washing the eustachian tube?
Washing it?
Yeah, washing it.
Well,
Gently wash. I mean, not a power wash, obviously.
well, we do frequently recommend nasal sinus irrigations. Treat their sinus disease, their nasopharyngeal disease, and some of that will splash up against the eustachian tubes as well. So patients aren't going to want to stick a catheter back there and squirt it into their eustachian tube. It would be awkward.
Yeah.
You also have the back foot.
Oh,
I mean, the other thing you have to worry about anytime you're using any kind of things like that is any kind of insertion into the eustachian tube increases the middle ear pressure, which Sudoff's done some good studies that show that can cause tinnitus, sensorineural hearing loss, and others. So vertigo. So being careful about how cleaning out the eustachian tube or manipulating it without some sort of ventilation port is important.
And generally, it's not necessary because you don't have a reservoir right there. You know, the cartilaginous eustachian tube is funnel-shaped, and there's this pumping action as it closes. So it's generally, as long as you can treat the rest of the orifice there, It's going to be
But
self-cleaning.
suctioning is okay, correct? Like in this particular case, we're suctioning the debris, biofilm, whatever. This is severe chronic nasopharyngitis with, glue-like pus sitting in the nasopharynx, and you can see it's very sticky, etc. One day will come, we'll be treating medically or infusing medications into the Eustachian tube, but it's not today, it's not maybe tomorrow, but next week.
Well, so this patient's got upregulated MUC muck genes, creating this inflammatory response. So the question is, what's the root of that inflammation, and how are you going to treat that medically? Just suctioning that kind of mucus is a very temporary measure.
Dr. Swan.
What happened to the use of surfactant? That died on the vine. That was something that held a lot of promise.
I mean, all I know is there was this company and raised money and for research, but it never came to a viable product.
This was Sujana Chandrasekhar's project, and she did found a company. Full disclosure, I was on their medical board, and it ultimately did go to a clinical trial. I think it was in Israel, but it did not meet the endpoints, and they did not get funding. They thought that redoing it might get past that, as often happens. The first clinical trial fails, but it's not been funded. So if you want to raise some money. It's still a good idea. Surfactants could help clear some of these secretions in some of these cases.
I mean, I've anecdotally talk about washing. I had chronic Eustachian tube dysfunction for a couple of years and wouldn't get better with medical management. And this was when my kids were young, and my son jumped into the pool without a lifesaver at the deep end. And I jumped after him. I couldn't control my nose or clip my nose and hold my breath. Water went in and cleaned my Eustachian tube out. Never had a problem since. So I don't know if we can debunk it, but it actually worked for me personally quite a bit.
That's how Joe DiBartolomeo invented the patulent. It was the same thing, the chlorine from the pool, but the FDA nixed him when he tried to patent chlorine drops for the nose.
Why we have quality of life tools that stuck at 7 and it's not progressing, like nose 18, 20, 22, etc. Are we happy with this tool? It's validated, obviously, but is this where we're going to be? Are we going to add more questions in the future to examine the functionality of the Eustachian tube better?
Well, so this was Ed McCool's work when he was a fellow with Vijay Anand, and he studied for his MBA how to do these kinds of validated questionnaires, and 7 was kind of a magic number for something that the patients are likely to fill out for this purpose. So you get a high rate of success in your patients doing this on a repeated basis. This is a symptom score, as you've pointed out. It's not a diagnostic score, and it's been misused frequently as a diagnostic score. But anything that causes oral fullness, all the things that Karen talked about will come up abnormal on that. So this is not the end of the story. In fact, popping and clicking, that's usually a TMD or a patulous patient, not an obstructive dysfunction. So there have been some other iterations. Cambridge, same issue. It's just symptoms. It's not diagnostic. Stay tuned. We're getting close to having a validated quality of life, symptom, and a diagnostic scale. So far, it's looking good. Hopefully, it's coming out soon.
By the way, if you have any comments, questions, please jump in. So let's go back to yeah, I'm sorry. I go ahead. Woo.
Can you address pediatric sinus disease then? Because you talked about the 8-year-olds. Is your pediatric sinus disease as part of the paradigm there to get that cleared up as well before Eustachian tube dilation?
Well, we don't do any peds in our practice, so I'm going to pass the mic.
I mean, I think that the answer is kind of the same as all of us. If they meet the same criteria and everything, and they have just like if you were going to be seeing a patient put tubes in an 8-year-old for recurrent disease and they had sinus disease, I would keep the same paradigm that you're used to. In my practice, I do treat the sinus disease as well. I do more of a limited sinus resection, but most of the literature shown even in an 8-year-old, it doesn't change the shape of the face or the functionality later on. So if they do have chronic sinus disease, you've controlled for reflux, you've controlled for all the other things, doing at least an enterostomy in the maxillary is I think a good idea. At the same time, but it really for me and in my practice with pediatric Eustachian tube, if I'm going to be, when I used to put a tube in, that's now when I use the balloon. And it's just interchangeable. It's got a better safety profile than the tubes. Doesn't interfere with the drum. Doesn't have the sequelae of a retained perforation 2% of the time. No hearing loss from the scars in the eardrum. You don't have any of the chronic otorrhea that you get from putting a tube in. And they can go swimming the next day. So the parents are happy. So if you're going to normally treat the sinus disease at the same time, I'd do it. If not, I would definitely make sure they're on maximal medical management, including reflux disease or medications.
One point to remember in pediatrics, the prevalence of sinus disease is less, chronic sinus disease like you would see in adults. So really think about allergy as a possible underlying etiology.
I mean, I haven't done I see significant pediatric patients, but I haven't done a pediatrics sinus case in the last 5 years if it's not a syndromal child or cystic fibrosis or some other reason. We can control most of them medically, adenoidectomy, plus minus a tube if needed.
Yeah, I'm sorry, go ahead.
So Dennis, in Miami, we do a lot of these for barotrauma, people that have trouble diving, flying. In fact, that's the only thing I do it for, with like an 87% success rate. Impossible now to get them approved by insurance, which is strange because it used to happen a lot, but we're getting denials all over the place because they have normal Eustachian, normal tympanograms at sea level. And I'm sure we all face this. And again, it used to be not a problem 2 years ago. Now it's impossible. Any idea how we're going to overcome this? Because this is the #1 best indication for this procedure.
Yeah, I totally agree, and I feel your pain. This is all about advocacy at our academy level and local medical society levels. So we won that battle in Blue Cross Massachusetts, and they went to Blue Cross America. But the BCBS-A, America, refused to approve the barotrauma. Really don't have an explanation. We've sent them tons of data. It's just going to ongoing pressure from every direction. That's going to be the answer.
I have pretty good success getting it approved by what I do is before a flight or before they have any kind of issue, they'll have them come in and we'll do a myrigotomy and document that it's relief of symptoms. And so most of the insurers, especially when I do a peer review, the question is they say, well, how do you know it's not something else? And by showing objectively that they've done a myrigotomy and they're symptom-free during that flight, and then afterwards, they usually will then approve it afterwards.
Another point, if they won't approve the balloon, I'll bill a 31237, like a sinus debridement. The patient's expenses will get paid. You won't get paid much, but at least you can get the case done. So that's one of the things I've done. They will not get paid for the balloon, but we've studied that, and they said it was a wash. So they were going to shut me down, and we got that through when they reviewed 10 cases. They were still making a profit, so we get to do it. You bring up a good point, though. If the military is doing a lot of these in the aviators and submariners, and if we could get that data to the civilian side, that could be helpful.
Can you pick up some of that negative pressure right after they dive? So a lot of times, a lot of people, if they're flying, I can get them in the clinic right away, and then if you can just document that they have negative pressure, then that may help ease that over.
We just a little bit out of pocket. We just ask them to pay, and they just pay.
Maybe we need to start having tympanometry machines at the airport, and everybody can just go up and have a quick tympanogram, on their way in. Just a proviso, anybody that has severe laryngeal reflux disease like this, for God's sakes, make sure that somebody along the pathway thinks to get them in for an EGD. I've seen some folks, and it's kind of always the least common denominator, you know, it's who's easiest to get into, and stress that they need to have an EGD, because I've been amazed how often they have not. Even if they respond to PPIs, even if they respond to treatment, get an EGD.
Good. Let's move forward. So we mentioned the Osman's fatty tissue around the Eustachian tube. And if you look at the anatomy, this is the major one, the inferior or the medial, and there is a superior one. This is the lateral one, the superior medial one as well, around the fossa Rosenmuller. These are the anatomic dimensions of the Osman's fat pad. There is plenty of literature in the Japanese paper, etc., treating the Osman's fatty pad and improving Eustachian tube function. And so I'm going to show you a couple videos and how I deal with that, and either under general anesthesia or in the office. And this is the inferior one, the one on the left-hand side, and debulking and decreasing the size of this structure. It's quite easy, and you don't have to go interstitially. You can ablate that by applying heat to the mucosa. At least you're bringing the soft tissue down to the base. And Dennis, any comments?
Well, so what you've got there is this redundant band of edematous mucosa running along the floor. There is some fat underneath that.
Yeah.
But I think your laser is going to be sufficiently superficial that what you're probably doing is eliminating some of that biofilm, which we think is one of the reasons why these lasers, the microdebriders, turned out to work. They worked better than we thought they would. You're just treating a small patch of the mucosa. You're not even treating circumferentially, and yet they could still get good benefit. Now, I suspect you're doing the same.
So our experience with Osman's fat pad is with Tepeza. Tepeza is a drug used for Graves' orbitopathy and for proptosis. And its action is reducing Osman's fat pad as a side effect, including intraorbital fat. So a lot of these people who are on Tepeza end up with Eustachian tube dysfunction of the patchless Eustachian tube. So at least there is some data that shrinkage of this fat will affect the function of the Eustachian tube.
Interesting.
Same as weight loss.
Right.
And that would be the risk of treating, I mean, you were treating it outside the tubal orifice, but like if you were going to treat that within the tubal orifice, you would have to be really careful, just because the problem is you don't know how much the body's going to, there's absorption rates of fat in the scar and the inflammatory process to get it just right. I mean, to make sure you don't create a patchless Eustachian tube will be
so
difficult.
Go ahead. I'm sorry.
You know, talking about side effect of medications, and with all the diabetes medications now, and people are losing weight right and left, are we experiencing an increase in patchless Eustachian tubes?
The Osimbic and all the others, actually, because of the way that they stopped their gastric emptying, their LPR has gotten significantly worse. So we've had a lot of patients that are well controlled for a while. They now have so much acid reflux that it's actually causing Eustachian tube dysfunction in people that didn't even have any for years. I've got patients that are coming in that we've gotten tympanograms for 6 years. They had more sinus disease, everything like that, and then all of a sudden now they actually have Eustachian tube dysfunction, even though they lost 30, 40, 50, 100 pounds, and it's all because of the reflux.
Will it swing to patchless then as they lose weight?
It could be. I don't think that, I mean...
Dennis talks about the spectrum of Eustachian tube dysfunction, patchless on one end and obstructive, so maybe they're more obstructive now because of LPR, but as they lose weight, will they increase the risk of patchless?
Well, I can tell you anecdotally, I'm hearing from people around the country reporting what they're calling an epidemic of patchless with these GLP Well, no, they're trying to avoid it, but these patients are walking into the office with these weight losses from the GLP medications, and so it sounds like I was unaware of the reflux issue. It sounds like it could go both ways, and unfortunately, that's what we see with Eustachian tube disorders, that they can go one way or another, or even change in the same patient.
Interesting.
So, Dennis, you and I would disagree in treatment of synechias and bands around the nasopharynx. And I tend now to agree with you that releasing bands due to scar, adenoid scar, etc., practically does nothing to the Eustachian tube function. Is that the conclusion? So we shouldn't get too excited about, oh, there is a scar tissue or a band.
Well, I agree. So the valve of the cartilaginous Eustachian tube is about 20 millimeters long. So it goes way up there toward the skull base. And so these bands are just affecting the most distal part. That being said, I did see one paper where some patient had a band that was contributing to patulous Eustachian tube. The author lasered it, and the patient was cured. But we've heard many, many other people who've lasered these bands with no benefit.
I've actually lasered some bands with benefit, and a lot of them that are not. I think it really depends. If you again, this is the importance of endoscopy. If you're like the one that you have there, it's still probably a little bit distal. If you were to have a 45-degree scope in the nasopharynx, a lot of times I'll see a scar band way up in the fossa of Rosenbuehler that goes the length of. Usually the scar bands that are effective aren't just that little tiny little. I mean, they're usually 4, 5, 6 millimeters in length. And it's actually hard to clip them and not have them come back because of the where it sits. You've got to put, I usually put either a gel, some different kinds of gels and things like that to try to help prevent the scar tissue from coming back. But it's it's probably 1% of all the patchless patients I've seen, and a lot of times when you do it, it doesn't help get them better. But I do clip them when I'm in there just because.
Yeah, and Mark brings up a great point. If you really want to see what's going on, is that making a difference? You want to look up the lumen of the Eustachian tube as far as you can see to see if it's mechanically causing a problem.
I mean, the question here is there effective placebo effect treatments to Eustachian tube dysfunction? I mean, is the patient feeling better just because we did something?
Well, that's a great question. That's at ETDQ. So we always want to couple our results with the objective findings. What do you see on your audiogram? Did you fix a conductive hearing loss? How's the tympanogram looking? How's their patulous test looking? Do they have excursions of the tympanic membrane with their nasal breathing? And you can augment that with ipsilateral nasal breathing. Opposite nostril closed, mouth's closed, and they're only breathing through the ipsilateral side. You can make the eardrum move if they're patulous, and you can see that with more sensitivity on a tympanogram. You run the tympanogram on reflex decay mode, so you get a 15-second window where the pressure's not being changed by the tympanometer. That's a great patulous test. So great point. Get some objective data.
And I would say that in the last, and I don't know if this is true for you, Dennis, but in the last 2 years, I've seen a significant uptick in patchless Eustachian tube secondary to balloon dilation, and it was done based off a symptom score, not done on and they hadn't had any tympanograms done beforehand. So I would say that, and they ended up having a lot of other things, superior canal dehiscence, other causes of it. It may not have had patchless to start, but they since caused it, and it's a much more difficult, at least I've had more difficulty controlling patchless post-balloon versus somebody that develops it naturally.
Tubal tonsils, Dr. Kacker. When you do, you mentioned adenoidectomy. So can you explain the method of adenoidectomy you perform if you see excessive tubal tonsils present?
So if it's electively, say 25% or less, and it's centered at the tubal tonsil, I do a transnasal electrocauterization method, which we suction bovie the bulk of the tubal adenoid tissue, peritubal, make sure we don't scar the lateral aspect of the tube, which is the opening of the Eustachian tube. So we tend to stick to area of fossa of Rosenmuller and follow it down but not trying to affect the lateral aspect called synechia or adhesions.
I completely agree. I do it all the time, especially in the pediatric patients. They've had a previous adenoidectomy, but usually that lateral adenoid tissue is still there. So we'll do the lateral adenoid and trim that medial half of the torus, the tubal tonsil tissue at the same time.
I do the same. I find that I can only see it really with transnasal with endoscopy. So then I can make sure I avoid the eustachian tube orifice itself.
I mentioned the posterior nasal obstructing type of turbinates. There are also swell bodies that can contribute to nasal obstruction. Those structures has anything to do with the function of the eustachian tube or not?
I think everything that contributes to nasal obstruction, whether it's deviated septum, turbinate hypertrophy, and the swell bodies, all affect the ventilation and can affect the eustachian tube orifice or eustachian tube function. So I do tend to treat those to improve nasal airway.
Obviously, I mean, the nose is a wind tunnel, and you got a whole bunch of airplane wings basically sitting in there directing airflow. I think that trying to single out just a single one of which one's going to cause this or that would be difficult. I think that if they do have complaints of nasal airway obstruction, plus they have objective findings of eustachian tube dysfunction, I would definitely do it. There are studies that have shown there are specific types of septal deviations that actually will when you fix that septum, it will change objectively a eustachian tube function test, but of the 6 different types of septal deviation, there's only one. And it's more of the posterior-based one. So I would say that it wouldn't be why I was treating the septum. I would do it if they had nasal airway complaints and everything else. I wouldn't do it as a standalone.
Once the older methods, not older, the newer methods came up 4 or 5 years ago, people started doing 10 swell bodies in the nose using 30117 code. So it was so misused that today, if you bill 30117 as exclusionary code, you can't get that approved, even if the patient needs it. So we became our victims of our own misuse of a code, that even if a patient needs it now, we cannot bill for it, or the CPT code is not usable.
Okay, let me show you an interesting case of a total nasal obstruction after full turbinectomy. There is severe hypertrophy of the turbinate structure that was left in the back of the nose. We resected that in the OR. This is a week or so after the procedure. And part of the septum also was treated. So if you look at the 4 weeks after, and Dennis, this is the question to you. There is no choana. There's one choana. Everything is wide open. You see both eustachian tubes. Turbinates are gone. The mass is gone. Airway is fantastic. He still has earfulness.
Well, the question is why? Is there normal pressure in the ear? Is the tympanic membrane normal? Do we have evidence that there is a eustachian tube problem? Do they have a patchless eustachian tube? So does he have an empty nasal syndrome? There could be a lot of different causes. And many times these patients also develop TMD from all their stresses. They're clenching, and they've got pterygoid muscle strain that refers to the ear. So you have to sort through all of those things, but I wouldn't blame it on the eustachian tube until you see some objective evidence.
I'd also look at his sinuses.
Yeah.
Just maybe.
Okay, we'll proceed.
What did you do? Yeah.
Excuse me? What did you do? I ballooned the tubes. Still has chronic issues. He's a bit better, but not much we can do.
Did you have any kind of audiometric? Did you have audiometric signs of pressure or fullness at the time, or did you not get tympanograms, or do you know?
Well, again, the sinuses are clear. We're treated. He had endoscopic sinus surgery and the total turbinectomy elsewhere many, many years ago. And that's why the hypertrophy of the posterior turbinate is blocking the entire airway. We took that down thinking airway will improve, Eustachian tube function will improve, did not. We ballooned them, helped a little bit, and we left it at that.
I think what Mark is alluding to is there an otological reason for this fullness in the ear? Is there high drops, for instance, which
Yep.
You would test for, people who have chronic sinus disease may also have chronic inner ear disease, and it could be hydropic. So as you were thinking, I think an audiogram, electrocochleography, and so on would be part of that workup as well.
One point, again, on these oral fullness patients, I've seen a number referred to us to do a revision balloon dilation after they've had 2 or more. And they get some temporary benefit from the balloon. And it turns out some of these have had temporomandibular disorders, probably a lot of tension in those pterygoid muscles. And I think what's actually happening is they get an expensive massage of the pterygoid muscles with the balloon, and they get some temporary benefit. So they feel great after the balloon, and it only lasts a few days. And then they're getting these repeated procedures.
I mean, my question then would be is how aggressive are you in treating TMJ then? Are you going to do the Botox? Are you going to do the oral appliances? Or how do you work that in your planning and management of these patients?
Well, that's a good point. Well, because of these types of scenarios that come up every office day, I've learned to do a thorough examination of the muscles of mastication, masseter, pterygoids, the temporalis, and we'll make the diagnosis of temporomandibular disorder as opposed to TMJ. Most of these patients don't have a joint problem, and if you don't specify the difference to the dentist, they're going to look in the wrong direction. They'll get an MRI, looks normal. Your doctor's a quack. You don't have TMJ. So you have to recognize TMD. If you can make the diagnosis, you want to link up with an oral medicine person. These people have these interdisciplinary teams with physical therapy. They can do exercises, heat, massage, ultrasound. They're the ones who can do the Botox. I've done some, but I don't want to get into that routinely. So link up with a really good oral medicine. One of these people, they're saints, who's done a residency as a dentist in non-surgical TMD management.
So I have one of those, and he sends me all his patients that don't get better to look at the sinus now for it. So I actually get more referrals from him than I give him. But I think that the one thing that I would stress with all of this, and I think that all of us would agree, is this is a functional problem. Oral fullness is a symptom. There are a lot of other things, and you should be able to see on audiometric functional testing that there is a ventilation issue with the Eustachian tube. Even for barotrauma, right when it happens, or if you do a tube, the symptoms should get better. Doing it because they have fullness, if you can't find something that relieves their fullness, dilating their Eustachian tube is absolutely the worst thing you can do. Because fixing it, if you do it wrong and cause patchless, it's incredibly difficult, and it requires surgical interventions, a lot of other things. Usually medicines don't take care of it, and so I really stress, especially for all the rhinologists doing it, is make sure you have some sort of audiometric team to be able to actually either work them up or get at least a simple audiogram and tympanograms as well.
Yeah, this work that Mark and Karen are doing with this relationship between the sinuses and these neurological pathways of causing oral fullness. This is a new frontier. So watch, you're going to be hearing a lot more about this, and I appreciate the work you're doing.
Jack, yes, Howard?
Yes, as a rhinologist, a big part of my treatment plan is using saline irrigation. The literature speaks about ear fullness using saline irrigation by any method. Has the panelist seen this, and can they explain why the ear fullness occurs? And then secondly, is it always self-limited, or is it, does it persist and require treatment, and why?
We've seen this. I mean, a lot of my patients post-operatively, when they start rinsing their nose post-sinus surgery, I would say 5 to 10% will end up with effusions and fluid in the ears. So I don't know if it's a function of force, is a function of irrigation and swallowing, or there are some other factors that the sinuses have packing blood and the fluid will take the path of least resistance. So they do get fluid in the ear post irrigation in sinus cases. The good news is most of them will recover without any further intervention. They just tell them to tilt their nose down so you don't really irrigate the nasopharynx, but the sinuses get back down on the pressure, and they're using a mechanical device to go down on the pressure as well.
I've seen it more with hypertonic saline. It's more of an irritant. But if they're patulous and that's causing their fullness, it can go right up the eustachian tube and cause some pain, pressure, and even middle ear effusion as a reaction.
So I've seen several different types, and one is very much the patchless patient, especially if you've given a bunch of steroids and a lot of other stuff right before pre-op. They may not be chronically patchless, but they'll have some degree of opening. And I actually get a reflex decay on all of my patients that have any kind of ETDQ7. And there's a lot that have no real symptoms, but they still have significant openings of the eustachian tube. Those usually do, and I actually, to give you a free plug, I do use Navage on those actually quite well because of the vacuum suction to the nasopharynx. They seem to tolerate that one a lot better. There's also stuff that I'll talk about later is through stimulation of the first branch of the trigeminal nerve, you will get a lot of oral fullness, and that a lot of times what's happening when you're doing the rinses is you're basically overpressurizing the sinus because it can't get out while you're still cleaning things in and out. And so those are usually self-limiting. Those usually will go away as soon as the rinse comes out of their nose when they lean over.
One takeaway point, patulous is far, far more common than we ever imagined. There's studies from Japan, 6-7% of the population may be running around with some degree of patulous. May not be pathological, but it's extremely common. And I see one patient a week in pediatrics referred to me for a balloon who's got middle ear effusion because they're sniffing, exactly, and they're patulous. It's very prevalent.
Jack, can you tell us about the famous Silverstein wick to the ear through the tube and the impact of steroid medication to treat the eustachian tube function? I heard published that on that, but I want you to, since you're on the panel, tell us about that, please. Go ahead. And this is going to lead to something else, obviously.
You're putting me in a difficult situation
no, it's okay.
right now. Herb, can you leave the room for a bit? Well, I think steroids have played a major role in our addressing middle ear disease and inner ear disease, and we use the intratympanic steroids if the patient has reasons not to use oral steroids. So oral steroids for us would be the first level of attack against autoimmune disorders, allergies, and so on. But sometimes we have patients who have ulcers and hypertension and so on, and eye issues, and they cannot use steroids, so we use the micro wick. So there are two ways to address, to put steroids in the ear. One is the Silverstein micro wick, and the other one is just plain injections, transtympanic. In here, we prefer the concept of the micro wick because it gives us a more sustained flow of steroids into the middle ear for eustachian tube issues, or the inner ear for inner ear issues over a period of 30 days, instead of having the on-off, once a week shot treatment where you put the steroids there and you swallow and it's gone. So we believe the micro wick is the better option, and we've used that for patients with sudden hearing loss, Meniere's disease, and some Eustachian tube dysfunctions.
Any increased risk of perforation related to that, since this is a long-term therapy or issues? There is some conservation while we're not doing that more and more. So what was the issue?
Yeah. So there is a risk of a tympanic membrane perforation once we take the tube and the wick out. It's about 5% risk of a perforation. Once we take the tube and the wick out, we basically freshen the edges and we put a paper patch routinely on everyone.
Okay.
So that basically reduces the risk of a perforation. It encourages the healing. If we still end up with a perforation after that, then we do what's called a fat laryngoplasty. So we take a little bit of fat from the ear lobule and we plug that hole. And that basically eliminates the perforation. It's very rare that we need to take the patient to the operating room for a tympanoplasty.
Got it. I'm not going to ask Herb to comment more on that. I think he may have some his own views, but I think you did a good job. So this leads into the next case. This is a patient that he had a balloon sinuplasty, balloon Eustachian tube dilation, and still have some issues. And he didn't want to have a myringotomy or a tube. And so we decided to go into the nose, deliver, this is a new type balloon that delivers, it's a soft balloon that seals the Eustachian tube entry, and we're delivering a micro doses of steroids inside the Eustachian tube. Now, the reason I like this case, because I told him to sit in the waiting room for an hour, and he comes back an hour later, I still see the steroid there in the Eustachian tube remaining. So the question is this a potential therapeutic opportunity for the future, Dennis? This is a single case. I cannot comment about that, but the concept was proven that I can go in there with an elliptical or triangular type balloon that delivers microdoses, I will say less than 1/3 of a cc of a steroid into the Eustachian tube. And it stayed there for an hour. What do you say?
I say we're looking at the future for treatment of Eustachian tube disorders. The one thing we've learned from all of these other interventions that have worked, the microdebrider, the laser, the balloon, they're all treating inflammation. They all reduce inflammation. And so there's lots of medical ways to reduce inflammation. It's going to begin with steroids, and there are going to be other anti-inflammatories and undoubtedly biologics and things in the future. The question is going to be how to get them there and how to keep them there. So this is a beginning. The one concern about sealing the Eustachian tube and doing an irrigation would be back pressure to the tympanic membrane. Actually, I guess, Mark, you studied a little bit of that, how that can cause pain even just from inserting a balloon catheter up the Eustachian tube. Any comment?
You can get over an atmosphere. So actually most of the research was originally done by Sudov, but without a vent to the Eustachian tube, I mean, even when you're doing these local awake, that's one of the reasons you actually know you're not in a false passage, is they can feel the pressure of the balloon going into the ear as it goes in. And yeah, just putting it in. And on top of that, I've actually reviewed some papers where they've actually done just this, and in fact, 40% of the people in the papers all had tinnitus afterwards. So one of the big concerns is the Eustachian tube is used to regulate pressure. If you basically lock it down and are putting in pressure into an already pressurized area, then you're going to end up getting a increased pressure. And is that enough to damage some of the structures or other things? Just depends, speed of time, secondary event. I mean, there's ways around all of those things, and I agree with Dennis. I think that this is the future. The problem is that at this point in time, is that steroid that sticks around enough? That may be great for an acute episode of Eustachian tube dysfunction, but like the problem with even in sinus disease, you need to use topical steroids all the time. Using them for just 2 or 3 irrigations and that's it, usually is not sufficient because it's an ongoing chronic inflammatory process. So maybe if you're trying to treat acute otitis or something, it would make sense. But for at least in this stage, you'd need something that would last a little bit longer, I think. Do you agree, Dennis?
Yeah, agreed. You know, again, about the discomfort issue and back pressure to the middle ear, as you instrument the Eustachian tube progressively, Luke Guinan studied this, comparing pain with awake balloon Eustachian tubes versus sinuses, and found that the pain reported was worse with the Eustachian tube balloon, and the pain occurred as they were inserting the balloon. So it was causing some back pressure just from a wave of mucosa inflating the tympanic membrane. And Mark, I think you even topically anesthetize the tympanic membrane for just that reason.
When I routinely do laryngotomies and all my Eustachian tube dilation in the office, it's just so much less discomfort for them. So they first do laryngotomies on both sides, and then I put the tetracaine ointment on the balloon itself as well.
I did do that, but again, you've got the risk of perforation from the myringotomy, and part of why you've done it and a lot of other things is to avoid that extra risk. And one of the benefits of the balloon is you don't instrument the TM. So what I started doing is putting a couple tetracaine drops of mineral oil essentially on the eardrum as they come in right at the same time as the afferent, and it worked just as well.
So again, it was the pain of the insertion it was not the balloon being blown up in the Eustachian tube that they complained most about. It was the insertion, the back pressure.
So is the pain from the middle ear increased pressure, or is the pain because of the local irritation from the ear?
And they'll tell you it's directly in there's two areas of pain when you're doing it under local. Is either, and if you ask them, it's when you insert the balloon, one of the things is it's the speed of insertion that you do, because a lot of them have a vent. So once it's in, then that back pressure is able to vent through the balloon. But that initial moving in, it's usually either blocked by mucus or it's blocked by just the speed of it, and it doesn't have a chance to ventilate. And then the other one is if you don't numb up the caudal part of the septum, a lot of times when you're not paying attention and you're pushing up against that septum, they'll say, and if you ask them where, it's the nose, and you just move your hand. But otherwise, it's deep in the ear, and it's severe neurogenic pain. Like I've had more than one person say it was worse than childbirth. Like doing it when I started doing it, and I actually moved it back to the OR. He said we have to figure out a way to do it in the office, so that's when I started looking at the neural pathways. And it was as soon as I put a couple of, and it's only about 25% of people. Like it's not every single case. It's just about 25%. That's the same thing that the Finnish study showed as well. But as soon as I started numbing the eardrum, they don't feel really. They feel a little bit of. They describe pressure in the ear, but they don't describe any kind of pain.
No. Does putting just a needle puncture in the drum, is that enough, or you have to do?
It's not so I've done that as well. A real myringotomy works better. Again, it's the speed of ventilation and it's really the size of the opening is how fast it's able to ventilate. So if you still have just a very small, let's say 25 gauge needle hole, and that pressure goes fast enough, it's still going to stretch the eardrum before it ventilates. You'll probably prevent some more long-term damage. I think again, Sudaf's got some neural as well.
I do enough to put a number 3 suction through the myringotomy, so that's a good gauge.
I also find IV sedation works exceptionally well.
Dennis, we put drug-eluting stents into the sinuses a lot. Why we're not putting stents into the Eustachian tube?
Sorry, go ahead.
Well, there are animal studies, cadaver studies, histologic studies, publications, stents into Eustachian tube in sheep, and you name it. So it's safe, but why we're not doing that?
They all plug up. That's the problem, is they plug up with mucus. So it's a great idea, but we have to figure out how to keep it open. And to date, none of those have worked. So we essentially put the equivalent of a stent as a shim for patchless Eustachian tube. That works great. But to keep it open and for drug delivery has been a challenge.
And I would say, again, it's not just to make sure we use the right term, you don't want a stent to hold it open. You want something more like a one-way valve or something so it can open and close. Because if you do have a pure, I've had some people put in catheters and things like that, and they become patchless because all of the sound and all the secretions go up if it stays open. The other thing is I've seen, so early on with Propel and others, we did put, I think both, I know Brian Weeks has had some experience with it, and I did the same thing and put a lot of steroids, and you can actually push them over again because of the fat atrophy, or the atrophy because of the steroid. You can get, I mean, you're really within 1/4 of a millimeter of being patchless versus normal, and so you've got to be careful how much you put in the long run. Luckily, they all reversed after time, but it's one of the reasons why everybody's kind of stayed away from the station tube till recently is you can't be wrong.
One case. I want to close with this last case. I need your advice, particularly Mark and Kacker. Tell me, this is a new patient I saw a couple of weeks ago, presented with some soreness in the throat. You look at the oropharynx, big bulging parapharyngeal mass. You look at the nose, it's filling the entire left side of the nasopharynx, crossing the midline, and obviously causing discomfort in the ear, pushing on the Eustachian tube, et cetera, et cetera. So we got a CAT scan and an MRI. It's fatty tumor. I thought we're going to see something other than fat. So the question to you, Mark, you're an established role model for me for minimally invasive procedures. I didn't do this case yet. How would you approach that, and what would you do? Tell me.
Liposuction?
So the first question I say is, what are we really trying to solve? So like looking at that on the Eustachian tube actually looks, I mean, it's not a 45-degree scope, but it's got good motion, and I'm not seeing any of that pushback that you see like from an adenoid pad. So if it's not really truly ear pressure and other stuff, I would probably essentially ablate that. I would put a bipolar in there, and just you can basically shrink that fat, because it's not, again, not knowing the symptoms and what we're trying to solve, it's not going to be aggressive. You've got the carotid behind there. If it's more of just he's got pressure and fullness either in the ear or the back of his throat for swallowing, you just needed to bulk the mass. I would take a biopsy of it when I did it, but there would be no real reason to do any large extension unless it came back as some sort of liposarcoma or something like that, which would be why you want to do a biopsy. But I've actually seen something similar, not quite that impressive, but it was a lipoma in that exact same area, and that's all we did is we basically just took a bipolar and just burned the fat, and it mucosolized over, and they did great. You want to make sure to keep the lateral wall of the Eustachian tube, keep the mucosa on that so it doesn't scar into the nasopharynx. But again, like right there is a good picture. You see the air bubbles coming out of the Eustachian tube and the muscle and stuff. I would be surprised if they have true Eustachian tube dysfunction, because that's showing air coming in and out of that pathway. So I wouldn't be debulking it for the Eustachian tube as much as for swallowing for the nasopharynx and their voice.
Yeah, the symptoms could be referred from pressure into the pterygoid space. So that,
the same innervation.
Exactly. So, by the way, always get a CT. We had somebody present like this with Eustachian tube obstruction, and it was a giant aneurysm of the carotid. Don't.
I would be the other extreme. We do a lot of these approaches for the C1, C2, and the dens transnasally. I would probably try to excise the whole thing with the mucosal incision and close it primarily. Oh, it's fat, so will deliver most of the fat successful. So as long as it's 270, not 360, most of the times we can deliver all the fat or even like cornosarcs and all safely.
Well, thank you, Joe. Thank you, panelists. I think that was a I think that was a good Eustachian Tube discussion. Somebody from New Jersey is calling me.
The name's Spam.
Spam, yeah. So, what's going to happen now, we're going to go for a little break, and then the otology and audiology lectures will continue to happen in this room. The sleep and sinus talks are going to be next door. And feel free to go back and forth if you are interested in one topic or the other. During the lunch break, there will be a industry talk in this room. Cochlear will be talking about their newest products and so on, and Earlens will be talking about their products and so on, and that's during the lunchtime. I think lunch is a boxed lunch, so you could bring your lunch and come back and then listen to them. Are there any industry talks on your end? Yes. The lasers talk are going to be happening also during the lunch break in the other room. This evening, after we're done here, we're going to the Le Barge, which is a wonderful way to visit Sarasota. It's the Sunset Cruise. Le Barge is a little ship that sails off the marina, very close to here. We could walk to that, except that we have to cross the circle, and it's risky to your life. So, worse than New York. Okay. People are still trying to figure out, what do I do now? What do I do now on the circle? And if there's a pedestrian, they go. So anyway, apparently there are going to be shuttles from here to the marina. So it'll be safer for us to just hop on the shuttle and go to the boat ride. We're supposed to be on the boat at 6:30, and the boat leaves at 7. We've had experiences in the past where people were left behind, so they don't wait for us. Anything else to say, Joe? We're good? All right, let's grab a cup of coffee and divide up.
Great job. That's a great discussion. Joe, that's terrific. Put it on the side. Yeah, put it on the side. Good.